second-year medical student at the Albert Einstein College of Medicine and also JOMA's Women's Health Committee co-chair. I want to thank everyone for taking time out of their busy schedules to join us tonight. We'll first be hearing from Dr. Moses about pregnancy, followed by a short Q&A. Feel free to submit questions either before Dr. Moses begins speaking or during her presentation, which we'll try to address afterwards. And now for just a brief introduction to Dr. Moses. Denise Moses, MD, FACOG, is a board-certified OB-GYN. Dr. Moses earned her undergraduate degree at CUNY Brooklyn and medical degree at SUNY Downstate. She completed residency at Hofstra North Shore LIJ Health System. She is a member of the Jewish Orthodox Women's Medical Association and prior co-chair of the Women's Health Committee. Dr. Moses owns and operates her private practice, Sunflower OBGYN, with 2 office locations located in Forest Hills and Manhasset, New York. She enjoys spending her free time with her children, seeing Broadway shows, going to museums, and educating the community. And now let's hear from Dr. Moses.
Hi, thank you so much for that wonderful introduction. Let's see if this works. I'm going to try and share my screen with everyone. Okay, so this is going to be talk about prenatal care. Just to start, like, when is the best time to start prenatal care? And really it's before pregnancy. So planning ahead is a really great way to make sure that we get all the nutrients that we need for a baby to grow. Make sure that we get all the testing done that we need to get done. Make sure that we get our immunity testing, diabetes testing, and anemia screening, as well as carrier testing. So there's 2 types of genetic testing. One of them is carrier testing. So it looks for genetic diseases like Tay-Sachs, cystic fibrosis, Fragile X, other stuff like that. There are different groups that create tests. One of them could be Dor-Yesharim, I know J-Screen, and a few others. We use J-Screen, we use the Horizon carrier screening in our practice, and as well as like Inherigen. And these tests nowadays are over 100 different types of diseases that people can be carriers of, which means that they have a gene for and they don't show the disease, which is important to know, because if 2 people come together and they both have the carrier of, they both carry the same gene, then there's a chance that they could have a baby with that disease. So a lot of the stuff we discuss talks about like prenatal vitamins, like what's safe, what is okay to do in pregnancy, what's not okay. So really importantly, I usually tell my patients you can start a prenatal vitamin like 3 months prior to pregnancy. We want that folic acid. It's so important because it protects against neural tube defects, make sure that the brain is forming properly. We want iron, calcium, and vitamin D. And then there's a really great list that came out in about 2018 of do's and don'ts in pregnancy. So I'm going to show that to you guys. So this was written by Dr. Fox. He's a high-risk OB-GYN, and he discussed like many questions that women normally have when they're pregnant. So it talks about like folic acid, iron, vitamin D, alcohol level, like weight gain, things like that. So this is a really easy thing to visualize and see that, he talks about prenatal vitamins. So you want 400 to 800 micrograms, all right, of folic acid. People usually have iron in their prenatals, but a lot of the times the first visit will screen for anemia, so we'll see if people need it. Vitamin D and calcium. There's no known ideal formulation for a prenatal vitamin. So people always ask, like, is this brand okay? Is this brand okay? It's likely fine, as long as it has those nutrients above that we discussed. Weight gain, I always tell people we're not eating for 2, we're eating for like 1.1. So we only really need to increase our diet by like 350 calories or so. Alcohol is not recommended in pregnancy at all, even though some people have said to me, like, oh, is a glass of wine okay? And things like that. We cannot know for sure at this point. Artificial sweeteners, a lot of people do ask about that as well. And they can be used in pregnancy. I always say everything in moderation. Caffeine as well is a huge question because a lot of us can't give up our cup of coffee, um, especially me. I know I had a hard time with that. So I definitely drank caffeine while pregnant, and it's totally fine to have a cup of coffee when you're pregnant. um, a lot of times talking about like how much fish and which fish has mercury and things like that. So, um, having salmon, tuna, those are really good fish to have during pregnancy. Um, Sushi. I was so excited when this came out because I was like, yes, like we can have sushi when we're pregnant because it's it has to be just prepared in a really clean environment. Um, the bigger issue is more infection that can occur, not so much the rawness of it. And then of course, like, foods, washing vegetables and fruit before eating it, like avoiding undercooked meat, avoiding unpasteurized dairy products. So usually in cheese, you just have to make sure that the ingredients say pasteurized. And deli meats, unfortunately, um, cold deli meats could be a problem because of listeria, which is an infection that can be very, very dangerous in pregnant women. Um, but, we usually say just warm it up, and then we can look on the CDC website that talks about foods that are being recalled for listeria contamination. So that's there. Um, Smoking and vaping, they really don't recommend, and it's something to discuss in terms of quitting uh, during the pregnancy. So, marijuana is also not recommended. Exercise is recommended. And that's a discussion to be had with your doctor or a midwife. It really depends on people's risks, but most people that have been exercising before pregnancy, we recommend to continue. Um, it's really good for mom, for baby, for labor. Exercising is excellent, but there are some women that shouldn't be exercising if they're high risk, if they have a placenta previa, if they're at risk for early labor. So these are conversations that pregnant women should have with their physician or midwife. We always recommend wearing a seatbelt in the car. People always ask about going to the dentist. Am I allowed to go to the dentist? And things like that. Yes, it's actually very important to go to the dentist when pregnant. Um, Hot tubs are something that should be avoided, but you can swim in a regular pool. Um, Insect repellents are fine. Hair dyes, everyone always asks, like, can I dye my hair? Can I get my nails done? Like, those things are okay. Um, Usually for getting nails done, I would try to recommend something that doesn't have as much of a smell, but that's just my personal preference. Um, for traveling, I usually tell my patients I don't really recommend travel after 34 weeks, but wherever they go, they should know, where the closest hospital is, where the OB-GYNs are, and just make sure that they're aware of what needs to get done at that point. Intercourse is fine. And one other huge question that a lot of people ask is it okay for me to sleep on my back, on my side, things like that? So it's not currently known. But what I do tell people is start off on your side. If you end up on your back when you wake up, it's okay. Just switch position. So we're going to go back to the slides, but this is a really great little article about, very, very common questions that a lot of people have in pregnancy. So during pregnancy, each visit is used to assess mom and baby. There's lots of tests that are done, and certain tests can only be done at a certain time in the pregnancy, and each trimester has its own set of tests. All right. So usually we start visits at around 6 to 8 because that's when we can see a heartbeat on the sonogram. So sonogram and ultrasound are the same. We we use them interchangeably, and a lot of the times we go with the sonogram, or we make sure that the sonogram is matching up to the first day of the last menstrual period (LMP) to get the most accurate dating for the pregnancy. So, in terms of determining the due date, this is probably one of the most important things that we do. And usually the first due date is the most accurate one. Um, so, if someone has regular menstrual cycles, we use the first day of the last period. If we have someone that has irregular cycles or if they conceive through IVF, we use other methods. We don't use the date of intercourse to determine the date of conception because the egg can be fertilized up to 24 hours after ovulation. Sperm can stay in the genital tract for up to 5 days, so that's not accurate. If the baby is measuring bigger or smaller, we don't usually change the due date because it's unlikely that there's an issue with the early due date. It's more that the baby is actually measuring bigger or smaller. All right. And then there are certain pregnancies that are considered to be inaccurately dated because someone doesn't know they're pregnant or they don't get a sonogram earlier on. So this is quite important just so it can carry over to the rest of the pregnancy, and the things that need to be done for the pregnancy do get done in a timely manner. So each trimester, the first trimester is 13 weeks to 6 days. The second trimester is week 14 to 27 and 6. And the third trimester is 20 weeks to delivery. And the fourth trimester is postpartum. Okay. So here we have a cute little ultrasound of baby. This baby is probably measuring around 9 to 10 weeks because you could already see the arms and the legs over here. So it's very, very cute. And we really do recommend that prenatal care is started in the first trimester so that we can get as much information as possible. So we normally will start with a history and physical exam. Um, so asking questions about how many pregnancies has someone had? Are their periods regular? Are there any ovarian cysts? Are there any fibroids? Any other um, history that we need to know about? Any medical problems? I always say diabetes, asthma, high blood pressure, any problems in prior pregnancies, any surgeries, any specific medications that someone's taking. We want to know about allergies. We want to know, um, do they exercise? Do they um, do they have good nutrition? Who do they live with at home? Any family history as well is all very important. And then physical exam is usually done, and and then blood work is done. So the genetic testing, as I talked before, to check for carrier status. We want to check the blood. We check it for anemia. We check kidney function. We check liver function. We check for infectious diseases. Some people check lead levels. Some people will check thyroid. Um, there are many, many tests that can be done in the first trimester. Of course, we want to do the sonogram, as I discussed, to determine viability and the due date. And then there's some other genetic testing that can be done. So this is genetic testing that's done for the baby, and it's more for chromosomal abnormalities for the baby. And also, it can determine the gender. Here we go. So, NIPS is also known as non-invasive prenatal screening, um, also known as cell-free DNA. So, essentially, it's a blood test of the mom, and it checks the baby's DNA that circulates in the mom's blood. And it can usually done around 10 weeks. And it does check for Down syndrome, and it can check for trisomy 13, trisomy 18, and the gender. And some of them are even checking for the baby's blood type at this point, and other genetic problems that can be found. So, um, you know, there's a very high detection rate. It could be performed at any gestational age after like 9 to 10 weeks, but usually we say around 10 weeks. Um, Sometimes it can test the mom's blood, but most of the time is pretty accurate. Then we have the first trimester screen, which is another blood test, and it includes a sonogram with the blood work. So the sonogram looks at the nuchal translucency, which is the thickness of the back of the baby's neck, and that's a Down syndrome test, as well as it looks for cysts in the neck, which is also very important to be aware of, um, and then a couple of different blood tests. And then going into the second trimester, there's a few different options, and then there's the integrated form of the first trimester and the second trimester. But normally in the second trimester, we'll add in something called the alpha fetoprotein, which is another blood test that looks for abnormalities with the brain and spinal cord. It is a screening test, not a diagnostic test. So even if that test does come back abnormal, that doesn't mean that there's absolutely something wrong with the brain and spinal cord. An ultrasound would be able to evaluate that further. Okay. Right. Another really important test that's done is the anatomy sonogram. So the anatomy sonogram is usually done like around 20 weeks, and that looks at all of the baby's anatomy. So that looks at the brain, it looks at the spine, it looks at the fingers and toes, it looks at the heart, um, kidneys, every single thing that is growing at that point. Looks at the umbilical cord, how many vessels are in the umbilical cord. All these things are really, really important. Um, there are times when not everything can be seen at the initial sonogram, so people need to be brought back a week or two later. That's very common. And then we also do diabetes screening, usually around 24 to 28 weeks, and that's the glucose drink that a lot of people dislike, but it's pretty sweet. Um, and screens for diabetes and pregnancy. And at each visit, we're looking for movement. We're checking the urine for glucose and protein. So glucose is sugar, and protein tells us about something called preeclampsia, which I'll discuss in a little bit. We check everyone's blood pressure, and we check everybody's weight gain. All right, so a little bit more detail about the diabetes screening. Um, it's a 1 hour, 50-gram glucose drink. So that's this one over here, the 50. They come in different flavors. Personally, I think the fruit punch is the best one, but a lot of the times people do like the orange flavor. It tastes like flat Fanta, to be honest. So basically, people drink the glucose drink, they finish it within about 5 minutes, and then their blood work gets drawn exactly an hour after. And it has to be pretty accurate. That's how the test was created. If someone fails the test, so different offices use different cutoffs, um, but usually the cutoffs will be between 130 and 140. So if someone gets in between that area, then they'll go for the um, 3 hour glucose drink. And usually you need 2 out of 4 to be diagnosed with gestational diabetes. So essentially, they drink the 100 gram. Um, After they get their first initial blood test drawn, which is the fasting, and then they drink it, and then it's an hour after that then 2 hours after, then 3 hours after. And 2 out of those 4 um, usually need to be elevated. If it's one elevated value, then we say that there's maybe some level of insulin resistance. And we kind of will work with a diabetes counselor, um, the high risk OBs, which is maternal fetal medicine, to determine if people need to get started on medication or if they just can have diet control. The baby's growth needs to be monitored further during the pregnancy. And then toward the end of the pregnancy, um, evaluations of the baby's well being. So, checks of the fluid, checks of the heartbeat, of movement, and also looking at contractions and things like that, as well as planning for delivery. Okay, in terms of weight gain in pregnancy, so these are the numbers for just one baby. And it talks about like the different BMIs and what the weight ranges should be. So usually we'll say for someone that's underweight, it's about 28 to 40 pounds. Normal weight is 25 to 35, overweight 15 to 25, and obese is like 11 to 20. So there's um, issues when people have excessive weight gain in pregnancy. Um, can lead to increased risk of C-section and other complications. So we are very cautious with that. And then many women don't gain much in the first trimester. A lot of people ask me if that's okay, and I always reassure them that it's pretty common because of the nausea. Okay, now going into the third trimester. So this is the after 28-week mark. Um, we we'll usually do a growth sonogram in my practice. I usually like to do one about 32 weeks, just to see how big the baby is and just get an idea how's everything looking. Group B strep testing and blood work. So group B strep is a swab of the vagina and rectum, and it tests for bacteria that normally lives there. Some women have it, some women don't. Some women could have it in one pregnancy and then not in another, which is fine. It just happens that way. But the reason why we test for it is because if the baby gets infected, it can be very dangerous to the baby. So, going back to discussing what preeclampsia is. So, preeclampsia is elevated blood pressure after 20 weeks, and then there's different forms, which I'll go into. But we take this very, very seriously over the course of the pregnancy, and we do a lot of monitoring and make sure that mom and baby are both healthy. So, these are the different forms of elevated blood pressure in pregnancy, and I just kind of wanted to go through each one because I know people really hear a lot of the different words, but you know, putting a definition to what you're hearing makes things a little bit more understandable, um, and less scary. So, gestational hypertension, gestational as in pregnancy, and hypertension as in elevated blood pressure. So, that means new onset of the top number of greater than or equal to 140 and the bottom number greater than or equal to 90 on at least 2 occasions 4 hours apart after 20 weeks. So, this could even mean that it can be at one visit and another visit. The, there's no real limit to the 4 hours as long as it's more than 4 hours apart. There's no protein in the urine, and there's no other signs of severe preeclampsia, which I'll go into in a little bit. Then preeclampsia is the elevated blood pressure 4 hours apart, and protein in the urine, um, as well as adding in the severe range blood pressure, which is the top number of being 160 or greater, and the bottom number being 110 or greater. So normally when it's that, we'll usually repeat it within 15 minutes because at that point we would want to lower that blood pressure. regardless, if someone doesn't have protein in the urine, but their blood pressures are still elevated, it's treated the same. So, still, very, very close monitoring, if needed, blood pressure lowering medication. Preeclampsia with severe features. So, it's patient with preeclampsia, and then the following. So, the top number of 160 and the bottom number of 110 or higher on two occasions at least 4 hours apart. Low platelets, um, liver function issues. So, meaning the liver function tests are at least twice the normal range, or severe right sided pain on the belly, closer to the top, and this is not responsive to medication. Kidney injury, so that shows on a blood test where the kidney function is elevated. Um, Pulmonary edema, which is uh, fluid going into the lungs, and visual disturbances, or more commonly headache, that doesn't improve with Tylenol. And eclampsia is a seizure that is seen in a patient with preeclampsia. Further on, HELP syndrome, which is um, low platelets, elevated liver enzymes, and hemolysis, like anemia in a, a patient with preeclampsia. A lot of the times, they also have the elevated blood pressure. And then we have people with chronic hypertension. So, people with chronic hypertension are people with elevated blood pressure before 20 weeks. Normally, it's um, even if it's diagnosed in pregnancy, um, this is also considered chronic. So it can persist even after delivery. And an important thing that we keep an eye on are people with preeclampsia. They can develop it not only during pregnancy, but they can also develop it during labor and postpartum. So we usually will monitor people up to 6 weeks postpartum um, to see if their blood pressure is going up. So I always will tell people, like, even if their blood pressure is normal, call if you're feeling any headache, if you're feeling anything unusual, things are not getting better with medication, let us know. Um, and then people that have chronic hypertension can also get what we call superimposed preeclampsia. So people with chronic hypertension, and then they have a sudden increase in blood pressure, and some of these people are on medication, then the medication is not working, so we need to increase it. Um, New onset of protein in the urine, and the other symptoms that can be associated with preeclampsia, like liver problems, kidney problems, etc. All right. And then they can have superimposed preeclampsia with severe features, as I was saying, the same. So the elevated blood pressure is 160 is over 110, low platelets, liver function problems, kidney function problems, pulmonary edema, which is the swelling in the lungs, and headache or visual disturbances. So we take this very, very seriously in pregnancy. Um, and that's also why we monitor everybody's blood pressure at each visit. Okay, so vaccines in pregnancy. There are multiple vaccines that are safe to take in pregnancy, but I just wanted to um, pick a couple to discuss because the way they work, and especially in the wintertime, these are kind of the more important ones to be aware of. So the way they work is the mom gets the shot, and then she makes those antibodies to whatever disease it is, and then those antibodies circulate around the body and get transferred to the baby. So the vaccine itself does not go to the baby. And I had a video, but first I wanted to show this. So this is ACOG, this is the American College of OB-GYNs, and it is a really, really good resource for people to look stuff up and get some information. So it talks about vaccines during pregnancy. And again, they talk about the same ones that I was mentioning. So the flu shot can be given at any point in the pregnancy during any trimester. Um, and again, it creates antibodies and it protects the baby until the baby can get their own shot. The whooping cough shot, again, same thing. And it's usually recommended between 27 and 36 weeks of pregnancy. Otherwise, it can be given postpartum, but then those antibodies are not going to be able to be passed to the baby. And that protects against whooping cough, which is the P in Tdap. That's pertussis. COVID-19 also can be given during any trimester of pregnancy. And it also creates the antibodies, which are protected and protective to the baby until the baby can get their own. And then the RSV vaccine is a newer one that has recently come out. RSV is respiratory syncytial virus, and it's a really common virus that affects babies and children and older adults. And a lot of children may need to be hospitalized um, because it really affects their lungs. So the fact that people can get this during pregnancy can really be protective against getting that disease. And it's really recommended if someone is between 32 and 36 weeks of pregnancy from September through January. All right. So important to know is that if people get the actual disease during pregnancy, they can get fevers and they can become much sicker than if they were not pregnant. Fevers are really not good for pregnancy. All right. And we know that vaccines do not cause any problems in pregnancy, birth defects, or autism, and they've been used for many, many years. The biggest issue we have is arm pain, usually. Okay. And just have a little video and hopefully it will work. But if it doesn't, that's okay.
When you're pregnant, you make a lot of health decisions. Since I was
I'll give it a minute.
due to give birth in the winter, I was worried about my baby being
Please hold while we're experiencing technical difficulties.
exposed to respiratory illnesses, like the respiratory.
I tried.
Let's try making it small screen and see if that will work.
I know.
Like the respiratory syncytial virus, or RSV.
Well, regardless, this video is on the ACOG website. So it's something that anyone can take a look at. I'm going to leave the URL up here. So, people can watch it on their own. Maybe it will work for them. I don't think it really wants to work for me. I'm going to try right now one more time. And then if that doesn't work, I'll give up.
So I made the decision to get the maternal RSV.
Okay, I'm going to give up for now. We will try it again later. Okay. The last thing, and probably also one of the most important things to discuss is mental health. So, more than 1 in 5 people can experience mental health conditions when they're pregnant or postpartum, and this can even occur up to the first year postpartum. So, something to discuss with your doctor or midwife, communicate what you're feeling, even if there was a screening test done earlier. And if something changes in the pregnancy, it's important to let us know what's going on. And then there's different treatment options, including therapy and medications. Okay. Communication is key for prenatal care. Talk to your doctor or midwife about your concerns. If you're unsure about a medication, safety in pregnancy, that's our job. That's what we need to know so we can talk about anything like that. OBGYNs and midwives' job is to know what medications are safe in pregnancy. And we wouldn't recommend something that isn't safe. We know what medications can cause abnormalities in a baby. And there are certain antibiotics and other medications that can do that. But most medications, especially the ones for nausea in pregnancy and other antibiotics, are quite safe. Your history is important. So, if you've had an extensive history, try and make sure you bring your prenatal records to your appointments. Um, you know, try and remember as much as you can. Bring your prior records over. Um, and if there were prior surgeries and stuff like the operative reports are all very important. If someone wants to try for a vaginal delivery and they had a C-section in the past, like we want to make sure that they had a low transverse C-section, which is a incision on the lower portion of the uterus, not a classical C-section, which is an up and down incision on the uterus. So these things are really important to work together to make the best plan for the pregnancy. And also you want to get your history from a reputable source. So for example, JOMA, FACOG.org. There's an Instagram called Babies After 35, which kind of is really amazing. She's a high-risk doctor herself, and she debunks a lot of myths. And also SMFM, which is the Society of Maternal Fetal Medicine, to get a little bit more information. All right. And I'm happy to answer any questions.
Okay, hi guys. So now we're going to be transitioning to the Q&A part of tonight's talk. Well, first, we also want to thank you again, Dr. Moses, for your time. We hope you all enjoyed and look forward to seeing you at our next webinar. But let's go to the first question we have for tonight. So one, is it safe to do laser hair removal after the first trimester?
So laser hair removal is one of those things that hasn't really been studied in pregnancy. It's not really recommended because the hair growth that women experience in pregnancy is different than normal. So we usually recommend not doing it at this point.
Okay, thank you so much. The next question that we have for tonight is what's the difference between like the NIPS testing that you mentioned and an amniocentesis?
So the NIPS testing is a blood test of the mom. All right, so it's the mom's blood that gets drawn. And amnio is usually done in the second trimester. It's done under ultrasound guidance, and it's actually done of the fluid that surrounds the baby called the amniotic fluid.
Okay, thank you. Another question that someone had is acupuncture safe during pregnancy, either for the body or just cosmetic facial acupuncture?
It's pretty safe. We actually tell our patients sometimes if the baby is breached, they can use acupuncture to try and turn the baby.
Oh, okay, cool. So
Yeah.
that's great for everyone to know. Another question that we had is what happens if someone's accidentally taking birth control while pregnant, that they didn't yet realize that they were pregnant?
It's actually usually fine. We just tell them to stop taking the birth control.
Okay, thanks. And then we have one more question for tonight. If you're trying to get pregnant and on birth control, when should you stop your contraception to get pregnant for the average couple?
You should stop when you're ready to get pregnant because anytime you're not taking birth control, you can get pregnant. Some people get pregnant right away. Some people it takes a little bit longer. But once you stop birth control, you should be prepared that you can get pregnant at any time.
Okay, That's a great answer. Thank you so much. We actually have a few more questions, if that's okay to go ahead with. Okay, perfect. So would you recommend aspirin in a woman with a previous history of a small for gestational age baby?
So there are recommendations regarding aspirin in pregnancy. There are people that meet certain criteria for having aspirin in pregnancy. Sometimes a small baby is not the only thing, but for women who it's their first baby, it's an IVF pregnancy, and they're over 35, those people we would definitely recommend aspirin. And if you want to give me a second, I can pull up the criteria and we can kind of go over it together so that people can be aware. I have my
Yeah, sure, go
ACOG,
ahead. That would be great.
I have my
Thank
trusty
you.
ACOG website because, these are things that I even pull up in the office when people are, asking me certain questions, and it just helps to show like what the guidelines are and like, this is where I get my information so that people can understand a little bit more. Um, Here we go. This is not what I want, though. Bear with me. Hold on. Here we go. This might give a little bit more information. My internet's extra slow today. So sorry.
No, that's okay. Thank you so much for pulling this up. This is great.
All right, there's a chart. Here we go. Here's the chart. Okay. So can you guys see?
Yeah, we see it.
Okay. Ooh, too big. Come on, internet. I think it wants to work, but it's not really in the mood. Okay, here we go. So here's the chart. So it talks about, risk level and things like that. So, so high risk are people that already had preeclampsia, multifetal gestation is twins or more, chronic hypertension, type 1 or type 2 diabetes, kidney disease, and autoimmune diseases. And then a moderate risk factor is first baby, BMI over 30, family history of preeclampsia, socio-demographic characteristics, age 35 or older, and personal history. So low birth weight, small for gestational age, previous adverse pregnancy outcome, or more than 10 years of pregnancy in between pregnancies. And then a low risk is like a previously uncomplicated full-term delivery. So in someone with a moderate risk factor, we want to have someone that has more than one of these.
Okay, great. Thank you. And then I guess we just have one more question for tonight. Is it safe to eat undercooked meat or fish or any of the other foods that you had mentioned while trying to conceive, or should it only be avoided once someone would get a positive pregnancy test?
Um, I think it should be avoided when someone gets a positive pregnancy test. I would be cautious because the bigger thing with eating undercooked meat and fish is the infections that can come along with it, food poisoning, etc. We just want to avoid that.
Okay, perfect. Thank you so, so much again. We really appreciate your time and
It's
your
a
effort
pleasure.
and all your great answers. So thank you so much.
Anytime.
And we hope everyone enjoyed also. And we look forward to seeing you at our next webinar, which is actually next week. I saw a bunch more questions that were more geared towards labor. So come next week to our webinar and you could ask those questions then. Have a good night, everyone.
Thank